Good morning. My name is Stephanie Evans. I'm a physical therapist with UI Healthcare, and today I want to talk to you about how you can help someone with advancing Parkinson's move a little bit better. I'm going to start by just reviewing some of the common movement complaints that we hear from patients, and then touch on some assistive devices and specifically walkers, because that's the question that I tend to get most often is what walker to choose. And then from there, we're going to look at some movement strategies of ways that a care partner can help assist through things like verbal cues or using visual cues and targets to help people move better. And I'm going to give some video examples of these ways to assist. So first off, difficulty walking. So with advancing Parkinson's, we oftentimes see either shuffling gait, freezing of gait, or festinating gait. Sometimes we see a combination, and they oftentimes do go hand in hand, but not everyone experiences freezing of gait or festinating gait. It's a common theme that we present is that everybody's different. So, but shuffling gait is when the step lengths become short or the stride becomes short, and then people don't pick their feet up. So you can oftentimes hear a scuff. Freezing of gait is when people feel like their toes kind of get stuck. Some people will tell me that they feel like they're almost glued to the floor and they have trouble stepping out. And then festinating gait is where I call it a runaway train. It's almost like the person looks like they get top heavy and they start to lean forward, and their steps become shorter and shorter, but they're quick. And so oftentimes that results in people going fast and kind of lacking control of their movement. Another common movement complaint is difficulty with sit to stand transitions. So most people will require multiple attempts to stand, especially with low surfaces like sofas and things like that. And when they go to stand up, they'll lose their balance backwards and have to try again. Our bodies will tell us that I need to scoot forward. If I'm in a deep couch, I need to scoot forward. But sometimes that can be really tough for someone with Parkinson's, and they will start to scoot, but they won't really get anywhere. There's just these short, tiny little movements that don't produce very much. Backwards loss of balance is really, really common. And not only when someone's trying to get up, but also when they go to sit back down in a chair. Sometimes people will start to sit and then become stiff and kind of fall back into their chair or plop into the chair. And then not turning fully to sit is another thing that can be really scary, because people will sometimes almost miss their chair, or it does happen where they do miss their chair when they go turn to sit. And then loss of balance is another thing that we commonly see in PT as a complaint. Parkinson's makes base of support narrow. So not only do people have shuffling gait where their step length will not be very long, but their feet are really close together. And so this becomes particularly problematic when someone goes to turn and their feet are already so close. They're going to have a tendency for a loss of balance. The other thing that we sometimes see is that the more impaired side tends to not want to move. And so the side that might move a little bit better will kind of cross over the other one as someone's turning and cause them to tangle up their feet and then fall. We talked a little bit in the previous slide about backwards loss of balance. The hard part about this is when someone does lose their balance backwards and standing, the ability to step and catch themselves is impaired. So sometimes people will try that they'll have that little step back, but it won't be adequate. And it ends up that they tend to kind of fall backwards, taking little teeny tiny steps. That's called retropulsion. Or the other thing is that they won't step at all. They'll just kind of get stiff and fall backwards. Forward loss of balance, we tend to see more when someone has freezing of gait or festinating gait, or they tend to let their walker get too far in front and they end up falling onto their knees. Another complaint that I hear often is reaching down for something on the floor. Sometimes people can't sense when they're outside of their base of support too far, and then they just keep going and fall forward. So some of the most effective and quickest ways that we can help someone who is having difficulty moving or frequent losses of balance is to find the right assistive device. And so it's really beneficial to work with a physical therapist to determine why the falls are happening, because that's going to help determine what's going to be the best assistive device to help the person. And then being able to actually go to a therapy clinic and trial the different devices can also be very beneficial. So like I said before, one of the biggest questions I get is what type of walker is going to be the best walker. And I'm going to speak in general terms, but again, I think trying these out is going to be most helpful if you do have questions. So this walker right here is a front-wheeled walker, just a standard front-wheeled walker. It's what we see probably the most, but oftentimes it's not the best for people with Parkinson's. And this is because they're pretty lightweight. And so as disease is advancing, that backwards loss of balance can happen more frequently. And sometimes people tend to take their walkers with them because they are so light. So they'll begin to fall backwards and pick up the walker. Or when they start to turn, they tend to tip it to the side when they lose their balance. This down here is a rollator walker. So one of the differences between this front-wheeled walker and this rollator or four-wheeled walker is that this tends to move a little bit easier. So for people who have freezing of gait, sometimes their freezing of gait is worse when they use the front-wheeled walker because they're thinking about how to move the walker the best way, and then their feet get stuck a little bit more. The rollator walker down here tends to turn and move with the person a little easier, and so sometimes freezing can be better. This up here is called a U-step walker. And the U-step walker was designed for Parkinson's. And the reason being, it's got a reverse braking system. So you have to squeeze the brakes to make it go. That's what releases the brakes. And then when you let go, the walker stops pretty effectively. It's a heavier weight walker. And it also has the design where you can increase the tension on these wheels here so that you could increase the drag a little bit. So if someone does have that runaway train type of walking pattern, you can help slow them down a bit. There is a cueing module on this one as well that it's an extra cost, but it shines a laser light down onto the floor that can be a target for someone to step over. So we're going to talk a little bit more about that later. And then this here is an up walker. So there's different companies that make this style of walker now, but it's one of the most frequent questions I get is, what about an up walker? Because as Parkinson's starts to advance, a lot of people will get the forward posture, and they are drawn to the thought of trying this upright walker that helps them stand up tall. I, again, have had success with it, and I've had people that don't really respond very well to it. One thing to keep in mind with this one is it is big and cumbersome, and so using it around the house can be challenging for some people. Okay, so on to movement strategies. So we can use things to try to help. I kind of explain it to people as we try to help trigger the brain to produce the movement. And so we can do things like counting. We can count 1, 2, 1, 2 as someone's walking to help produce the stepping. Some people respond better to saying left, left, left. And everybody is a little bit different. So we oftentimes in PT try different types of cueing to see what people respond to. A metronome is also something that can be helpful, and they're inexpensive, and it can offer an auditory click, click, click. for someone to try to match the steps to keep their feet moving. I've had kind of varied responses with metronomes. I usually try the verbal cueing first before we would try the metronome, but like I said before, everyone's a little bit different. Visual targets are things that you can place on the floor, or like the U-Step walker, it has a built-in laser light that shines to the floor. And this is a trigger for the brain. If the brain sees a target, it can help produce the movement to step over it. So I made a video here I want to show you. Turns are a very common trigger for freezing of gait. So sometimes visual targets on the floor can help with someone turning. So this is an example of coming down the hallway and having to turn to get around a corner. So having the visual targets on the floor can sometimes help if you know this is a problem area where you always get stuck. You can actually have targets to step over as you come around the corner. So I've done the same thing with through the doorway. People typically have freezing of gait triggered by doorways or changes in flooring surfaces. So I started the targets on this side of the door and followed it all the way through so people don't get stuck. Yeah, I can do audio. So what I used there is just painter's tape. It's often nice to use just because it doesn't cause damage to floors. And the other thing that I sometimes recommend is that you change the color every once in a while just to kind of keep the brain's ability to recognize it and not just ignore it. And so it comes in different colors. There's green frog tape and they're bright. So these can help just to trigger that movement. Weight shifting is another technique that we use. And oftentimes when someone feels like they're stuck and can't initiate movement, we work on just stopping, and then have them stand up tall, sometimes take a deep breath and start shifting their weight so that they can get their weight off of one foot in order to start again. So this is going to be an example of how saying stop can be a way that can be effective to just help somebody as they're walking, and you can kind of start to see that they're getting themselves into trouble. Saying stop is like a reset for the brain just to start over and try to produce more quality movement. Okay, so a lot of times people have trouble keeping the walker close to them when they walk, and they will take shorter and shorter steps. So the shuffle gets more pronounced, or they start to have festinating gait where they look like they're top heavy and their feet start to move really fast. So Dylan's going to demonstrate this, where the walker is too far out and it gets going a little too fast. So one of the best things to do with someone is to try to just say stop. So as he's starting to go, I can say, okay, stop, 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 stop. And he's going to try to stop himself and pull the walker closer as he goes. If that doesn't work and he can't catch it in time, sometimes giving a little pressure on the front of the shoulder when you first start to see it happening. So if you're here and he starts going and you first start, you give a little pressure, big step, take a step right in towards the walker. That can help. So either stop or big step can be really helpful. So one more time, okay? Stop, walker close, pull that walker in, and big step. Big, 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 big. So in that video, you saw that Dylan had a belt around his waist. And this is something that we use a lot in PT, but it can be beneficial for home. And I wanted to make a video on its use. I want to take a minute to show the correct way to put on a gait belt. So we mentioned gait belts as a way to assist someone with their balance or with transfers, but sometimes we don't remember that we need to teach people how these actually work. So you put this around the person's waist, and then the care partner should make sure that the teeth are facing outward towards them, and feed the end of the belt through the teeth part first, and then you're going to pull it through and cinch it up nice and tight, and feed the other end back through the other opening and pull. If it's still a little bit loose, you can easily take this little loop, pull, cinch it up a little bit tighter, and then it's in place. The most common place to put these is down low around the waist. Some people prefer them up a little bit higher, and that's okay too. And then to get them up, you just take it through the one, and then the easiest way is to pull on the buckle and slide it through to take them off. Okay, so these last slides, we're just going to go over some other techniques. These two are helping someone stand up from a chair. So those are the little scoots that are ineffective that I was talking about before. So that technique of leaning back and pushing the back against the chair, then sliding the hips forward, can be kind of a little cheat technique. Instead of having someone struggle with that forward lean and trying to do those short little ineffective scoots. So I'm going to come up and help with the gait belt. I'm going to show you on this side. And then I'm going to tell him that he needs to keep his eyes on his toes as he comes up. So we're going to count 1, 2, 3. Eyes on the toes. 1, 2, 3, and up. So right there, I should have mentioned that when people first get up, that can be where they tend to lose the balance backwards. And so having your hands on the back or on the gait belt just to stabilize and try to help them push them forward back into their center of gravity is smart. And just to make sure that they have a good, stable position before they start to walk. Some of my patients feel like they freeze in a seated position. And so this next technique is something that sometimes is helpful for that. Okay, so with this one, some people feel like they get stuck in a seated position and they just can't initiate standing up from the chair. So what sometimes helps is coming in and grabbing the hands and just doing a little rocking. So you're going to say, okay, just rock forward, rock back. So it's kind of like priming the movement. And then you can have them keep rocking on their own and they come into the gait belt where you then go 1, 2, 3, and all the way up. One thing I wanted to mention about this is a lot of care partners will come and assist people up from a chair by just pulling them forward like that. And so I think that can be an okay technique for some people, especially if they have good balance and they're strong enough to support the person. But one thing to think about is if you can have them start rocking first, it can just help you have to work a little bit less because you need to promote them leaning forward just to assist you. And some people will get really, really rigid and pull backwards or lean a little bit harder when they are doing the handhold assist. So it's something just to watch out for. Okay, these are some examples of turns to sit. Turning to sit can be really difficult for people with Parkinson's. So one thing that I tend to see is that as someone gets up close to their chair, they start to reach for the arm of the chair before they even get close. And so here, what happens is the feet get stuck and then people end up diving into their chair. And so the problem with that is as you come up, when the person starts to reach, the attention's taken off of the feet and to the hands. So the brain's thinking about what the hand's doing and the feet get stuck. The other thing that happens is that I'm shifting my weight over the foot that needs to move. And so I get more stuck because all the weight's on this foot that I need to move to get to the chair. And then I end up just flopping in and diving in the chair. So one thing that can be helpful is cueing someone to turn fully before they sit. Making it a big, big turn and then reaching back and sitting for the chair. Not grabbing for the chair before they even get close. So sometimes what's helpful is to get up and even say, okay, touch the chair with your leg, then turn and reach before you sit down. Sometimes visual targets on the floor can assist with turning to sit as well. So using painter's tape in front of a chair or in front of the toilet, and then cueing someone to get their feet on each X before they reach back and sit down can be helpful. So even with the walker, if someone's coming up to turn to sit and they start really getting stuck and having trouble, you can really focus on them getting their foot on each X before they reach back and have a seat. This can be helpful not only in front of chairs in the toilet, but also at the edge of the bed. It can help with lining up in the correct position or prevent kind of getting close to the bed and then diving in. The other thing to point out with this one is that with the turns to sit, sometimes people get really confused by what to do with their walker. And so if you get close, sometimes it's helpful to break it up and say walker, step, step. Walker, step, step. Walker, and then reach back and have a seat once they get close enough that they're safe. Okay, so sometimes freezing is one of the biggest problems for people. So they get stuck when they try to turn to get to a chair, and they really can't get their feet to go around. And so one thing that's really helpful is if you're needing to assist and they're getting really stuck, you can try to grab their hands and then cue for shifting weight side to side. And then they shift, they can start lifting their feet, and then you can take the lead and try to get them to come all the way around to the floor and then reach back and have a seat. Getting up from the floor. This can be a really big challenge. And I do want to say that when someone falls, you really should be assessing to see if there's any injury, and oftentimes getting some extra help is just a smart choice. But I did want to demonstrate how to assist somebody with use of a gait belt. This is something that I oftentimes do during PT sessions. And with care partners, they're just practicing so that they can have a plan if a fall happens and no major injury has occurred. Okay, so this one, we're gonna look at getting up off of the floor, assisting someone with use of a gait belt. So we've got the belt on, and something that can help is doing big arm swings. So we're gonna have them kind of swing his arm and count in order to get up to hands and knees. So first one, swing over and go. And then right here, that's usually a place where people get stuck. So you can grab the belt and help get the hips up and over to get to hands and knees. So we're gonna go here, and that's another one where counting can really, really help. And then having a chair close, you get the hands up on the chair, and then this is where it's hard for people to get the powerful movement. So they might have to have elbows down on the chair and really focus on getting the feet under them and taking small steps to get forward. So just go all the way up and step, 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 step. And then here you can hop it around so you get to the chair. Helping that turn, that last turn, because someone is going to have a tendency to want to kind of dive into the chair, is really important for that transfer. I did want to take just a few seconds to mention wheelchair evaluations. So, ultimately, it could be recommended that a wheelchair is the safest option for mobility. And a therapist can help determine if a manual wheelchair or a motorized wheelchair can be the best. And this process can be a little confusing. So, in order to get a wheelchair covered through insurance, you need a face-to-face appointment with a physician. And at that appointment and in that note, they need to discuss why the wheelchair is necessary. So recurrent falls, difficulty walking, things like that. And then they have to provide a prescription for the wheelchair. So our clinic does wheelchair clinic, we call it. So they have the physical therapist and a wheelchair vendor present at the same time. And what they do is work together to determine the best type of chair, the size for the chair, different accessories that may be needed. And so the PT is there to help provide appropriate documentation and recommendations. And the wheelchair vendor is the company of your choosing that you're going to order the chair through, and then will subsequently be able to make any repairs that are needed. It's important to keep in mind that sometimes this process can take some time, especially with power wheelchairs. It can take 3 to 4 months to get the chair. Typically with manual wheelchairs, that time frame is less, but it's important just to keep that in mind if it's something that you're thinking about. Okay, so that is all I have. I did want to provide our contact information here. Our department is rehabilitation therapies, and we're in the lower level of the hospital. And myself, Amy Yachty, and Thomas Steffen are the PTs who have experience with Parkinson's. And so please feel free to call if you would like to schedule an appointment with one of us. And now we're going to take a brief break. And then after that, we're going to return, and Rachel Rose from Occupational Therapy is going to present. Thank you so much.